Fantastic. Okay, well, welcome. We're going to get started with our sessions always run. We start with a mini didactic and then we go into cases. I'll introduce you to our interdisciplinary panel before we start the case that we have from Megan Feng, who's one of the Geriatric Medicine Fellows at the University of Washington. Hi, Megan. And this is her first Project Echo, and she was kind enough to present a case, not even knowing what she was getting into, but it'll all be fine. So I'm going to introduce you to Dr. Ong, who's one of our panelists regularly on Echo. He's a geriatrician here at Harborview at the University of Washington, and has expertise in a lot of different areas, but he's given a few talks that I've heard on hypertension in older adults. So I asked him to come and speak on this topic here for Echo, since it's a core topic for the care of older adults in the primary care setting.
Thank you very much, Kate. I will just go ahead and jump in. So just in the honor of the fact that it is Halloween coming up very soon, so I was asked to have a title that was related to Halloween, and so I was just thinking that it's not incredibly scary. But you would think that it's something that we've practiced for so long that we would have a clear, definitive management program that everyone could abide by, but that's not so much the case. So hopefully by the end of this presentation, we'll talk about some of the goals of antihypertensive therapy. We'll recall some current blood pressure targets in older adults. And then at the end of this, we'll outline a practical approach. And for you, I would really love it if you would share your practical approach to management of hypertension in older adults too, and share your clinical experience and ask questions as well. Before we move on, could I just do a sound check? Is my volume okay? Just a thumbs up? Great, just a head nod, perfect. So just a little bit of background is that hypertension is incredibly common and prevalent as a person gets older. And part of that has to do with just the natural aging process, as there's more calcium deposits and the arteries become hardened and stiffer as a person gets older. So by the time that a person is over 60 years old, 67% of individuals are likely to be hypertensive. So the prevalence most definitely increases with increasing age. And there's a recent data point in terms of the SPRINT trial that we'll talk about later on, is that is lower blood pressure truly better blood pressure that we should have? And so this headline was taken directly from the New York Times and printed in 2015 that was based upon the SPRINT trial. And it said lower blood pressure guidelines could be life-saving, federal study says. And so we'll dive in a little deeper, just because you may have patients that will ask you specific questions about the SPRINT trial data. Before we start on, we'll just review some of the basic guidelines and what is out there. And so this is the Joint National Committee, JN7, and this is what was recommended for hypertension. And so this was back in 2003, where they classified people with normal blood pressure as anyone that with a systolic blood pressure less than 120. And then if you had something that was below 140, in the range of 129 to 139, that was considered pre-hypertension, but not really defined as hypertension yet. And then as you had increasing degrees of increasing systolic blood pressure and also associated diastolic blood pressure, then you were either classified as having stage 1 or stage 2 hypertension. And then in 2017, very, very recent, the American Academy of Cardiologists and American Heart Association came out with these new blood pressure guidelines, and these are specifically related to adults. You could see that it's incredibly similar to the JNC7 in terms of how it's broken down, but the intervals or the cutoff points are different. So now normal is still defined as something that is less than 120, and that something that is considered elevated is now 120 to 129, and so that's actually considered elevated. And now hypertension is defined as someone who having systolic blood pressure of 130 to 139, stage 1, and then stage 2 is anything that is above 140 at this point. And so oftentimes you'll see these guidelines that are broken down by age. We skipped over JNC8, which was released back in 2013. And the reason why we skipped that over is that I just wanted to show you how similar JNC7 and the 2017 Practice Guidelines are in terms of trying to discriminate different levels of hypertension or the severity of hypertension. And in JNC8, they lumped everyone together in terms of describing a person over the age of 60 or under the age of 60, and then picked a level based upon, picked a systolic blood pressure associated with what's high or what the goal was. And you could see that everything, the top three categories of that top three columns are based upon the US. The things that are below that, the bottom three, are guidelines from our European colleagues. And so you see that at least in Europe and other parts of the industrialized country or world is that they pick a cutoff of 80 years old, actually. So they have different cutoff points based upon age 80 versus within the US, we considered quote unquote old as someone that is either 60 or 65, depending on where you want to pick your cutoff point at that point. And so we'll talk about what the specific goals of why are we talking about hypertension and why is it important. And I think that this is important just to talk about this explicitly a little bit. But the American Heart Association talked about that goal of having a blood pressure that was less than 130, systolic blood pressure less than 130. And the whole goal of this is to decrease in cardiovascular risk, because we know that higher blood pressure increases in a continuous association increases your risk for cardiovascular disease. And so they wanted to decrease cardiovascular morbidity and mortality that's associated with higher blood pressures. This is old data, but it's really important because it illustrates why it's important to control a person's blood pressure. And I'm going to walk you through this. This is based upon prospective data in older adults over the age of 65. They followed these individuals for 6 to 7 years, and they looked at before they lost their disability or had increasing disability, what was the medical condition that caused them to have disability. And so they were able to stratify patients. Actually, you can't see my pointer because it's white, but here is subset number 1 and subset number 2 that we're going to concentrate on. So subset number 1 is catastrophic disability. And so what they define as catastrophic disability were individuals who had no impairments in ADLs whatsoever, but then within the preceding next year that they had some sort of impairment in at least 3 ADLs or greater. And so that was catastrophic disability. So you'll see that in catastrophic disability, there were these diagnoses or conditions that cause individuals to have catastrophic disability. And then the same thing with progressive disability. Individuals who had maybe 1 or 2 impairments in ADLs, and then they had these conditions within these boxes that then caused them to have progressive disability, where that they had now 3 or greater impairments in ADLs. And you'll see that 3 out of these conditions are all related to cardiovascular outcomes, so stroke, heart failure, and coronary heart disease. And so it makes clinical sense that these are the conditions that we see clinically that cause people to have disability. Also associated with that is hip fracture, cancer, and of course pneumonia. These are some recent recent trial data, and these are all randomized control trials. And I stress that these are randomized control trials that we'll talk a little bit later on about as well why that is a point that we'll stress. You could see that from SHEP, and all the references are listed at the bottom of this table. HIVET and SPRINT. The mean ages are pretty variable, and these are the entry systolic blood pressures and the achieved systolic blood pressures. What you'll note about this is that there's very little people in any of these trials that are diabetics, and so the things that we talk about might not be extrapolatable to people who are diabetics. And the median follow-up time is pretty decent for the majority of these randomized control trials, and they were decent numbers as well. And what they showed is, taken in a nutshell, was that that by controlling blood pressure or reducing blood pressure to what their targets were, is that it reduced cardiovascular outcomes. So you could see that in taken as a whole, all these numbers that have a little star right next to them, those are statistically significant for reducing cardiovascular outcomes. So congestive heart failure, MIs, total all-cause mortality as well. And so it's taken as a whole. The data really holds up in terms of in this population, in randomized controlled trial settings, controlling for blood pressure does reduce cardiovascular outcomes and improves it. And so what is the SPRINT trial? So it was a trial where they randomized older adults while trying to achieve a more strict blood pressure. There's a lower blood pressure, systolic blood pressure goal of less than 120, reduced clinical events compared to systolic blood pressure of less than 140. These are some of their inclusion criteria. Basically, that a person had to have a presence or a presence of clinical or subclinical cardiovascular disease other than a CVA, or chronic kidney disease as well, and we'll dive into what that first inclusion criteria meant. So what the presence of clinical or subclinical cardiovascular disease meant was that you had to have a previous MI, some sort of PCI, CABG, or carotid stenting. You had to have peripheral arterial disease, you had some sort of positive stress test, or based upon some coronary calcium score that it was greater than 50% stenosis of a coronary artery, or you had a AAA that was greater than 5 centimeters with or without repair. And so these are some other parameters that they measured in terms of having subclinical cardiovascular disease. So you could see, taken as a whole, these individuals that they put into this study were decently high risk already, because if they had to have one of these things to include within the inclusion criteria, these are just decently high-risk individuals already. Some of the things that they excluded here, it's not by all means meant to be comprehensive, but I pulled out just the more pertinent things that I think that are really important to highlight, is that they excluded people without a history of stroke, because in clinical practice, we should be controlling these individuals' blood pressure as best as we can already. They also excluded people with a history of diabetes, again, so it's really hard to extrapolate what to do with diabetics. They excluded people with a life expectancy less than 3 years, and unfortunately the authors really didn't talk about how to do this, because I could tell you that I do a pretty poor job as a hospice physician even of giving prognostic indicators for 6 months, and so if you're going to pull that out to 3 years, I could tell you that I'm pretty poor at doing that as well. And so I'm not sure how they did this other than just clinical expertise. They excluded people who were unable to consent, so that took away people with dementia, with advanced dementia, and they excluded any people with a limited ability to have adherence. And so for those of you who practice in a nursing home, they excluded those individuals as well too, because so they wanted a population that individuals could come into the clinic, get their blood pressure checked, and have routine monitoring as well. Okay. And what they wanted to see was a primary outcome of a composite of all these cardiovascular outcomes. So either having acute coronary syndrome, a stroke, heart failure, or death from any cardiovascular causes. And there were some secondary outcomes as well. And what they showed was that their primary outcome was statistically and clinically significant here. And that's where you see the deviation or the separation in this blue line, which was the standard treatment, where that they were going for the blood pressure less than 140, versus the intensive treatment, trying to achieve that blood pressure, systolic blood pressure of 120. And so you saw that separation, and you saw that separation already in year number 1, which was actually pretty remarkable that you saw that already in year 1. And the clinical bottom line that was targeting a systolic blood pressure of 120 as compared to something less than 140 resulted in lower rates of fatal and non-fatal major cardiovascular events and death from any cause. And they also did a subgroup analysis as well. What I will pull out, and I think that was stressed for today, is that the individuals over the age of 75 and above actually had the most benefit, or had the most clinically significant benefit and statistical significance as well. And so for these individuals, 75 and above had the most benefit from more aggressive blood pressure control. And so you'll ask, well, what's the number needed to treat? And so for anyone over the age of 75 above, the number needed to treat was 27. And so you had to treat 27 individuals to prevent one primary outcome, and that was a composite outcome. So that number needed to treat is actually pretty darn good. Pretty darn good. So again, I will stress the clinical bottom line, but I'll throw in a caveat there, was that the clinical bottom line applies that it needs to be in the appropriate population. And so that's part of the reason we talked about the inclusion criteria, and that's part of the reason why we talked about the exclusion criteria as well. And so it's not something that you would want to extrapolate to, for example, someone who is frail in your nursing home and maybe non-ambulatory, for example. And there were serious adverse events that they reported as well. But overall, actually the serious adverse events didn't differ between the groups. There were higher rates of hypotension, syncope, and electrolyte abnormalities in addition to acute kidney injury as well. And as a geriatrician, I am most concerned about falls and bradycardia in individuals and changes in a person's functionality. Fortunately, though, they actually didn't show that there was a difference between any falls or changes in gait speed during this time interval. Okay. What I will go through here is to share our European colleagues' guidelines and then move on to kind of the clinical practice and management. So now that we talked about the sprint trial and talked about the appropriate data, well, what do you do with this information when families ask you, well, how should you practice? That's where you can actually garner some information if you dive deeper into the guidelines, where the European guidelines actually talk about people who are fragile elderly populations, and that's where I have it highlighted there. So they talk about in fit elderly patients less than 80 years old. Systolic blood pressure values of less than 140 may be considered, and so you can maybe even change that now to include sprint trial data. It may be in individuals who are truly fit and functional, that you could push their blood pressure a little lower. But in patients who are fragile and in an older population, it should be adapted to the individual. And then it also talks about if they are in good and physical mental conditions as well. And so that's the other thing that I want to highlight. And so you do have room to exercise your clinical judgment and also have guidelines to back up your practice. And if you go into the American guidelines, the ACCA and AHA guidelines that I started off with the discussion with, they actually talk about that too, actually. And so if you dive in and look at those guidelines, they talk about non-institutionalized ambulatory community dwelling older adults, calling that specifically out because they based so much of their recommendations on that sprint trial, and that's the population that was excluded from the sprint trial. And also a high burden of comorbidity and limited life expectancy. Again, they don't talk about how to prognosticate and what that limited life expectancy means, but it's based upon your clinical judgment, is that next sentence. So what do? I base it upon functionality, and this is some data that I would like to just walk you through because I think it's pretty important, and it actually probably reflects your clinical practice already. And so this is data taken from the NHANES database, and they took people over the age of 65. The mean age was 74 years old. They classified people as having high blood pressure versus low or normal blood pressure. And so people who were having high blood pressure was people they define as having a systolic blood pressure of 140 and greater. And anyone below that was considered normal. And it had data on a 6-minute walk on individuals. And so they asked these people to perform a 6-minute walk, and they clocked them at how fast they could walk. And so if they were walking at a 0.8 meters per second rate, that was defined as fast. What that translates to is about a 32-minute mile. So if someone was walking at a 32-minute mile, that was defined as fast. If they took longer than that, that was defined as slow. And then there was a category of individuals who did not complete it. So they stratified these individuals based upon their blood pressure and their ability and how rapid they were able to do their 6-minute walk to the probability of their survival or their mortality. And so the interesting thing that you see is, I'm going to walk you through this because it's really interesting, is if you grouped the faster walkers up here, people with actually a high systolic blood pressure had a higher probability of survival. Sorry, hold on. Let me walk you through that one more time, sorry. So people who had a faster walk speed, if they had a normal systolic blood pressure, meaning that it was less than 140, that their probability of survival was higher, less likely to die. And they found the exact same thing in patients who were slow walkers too, that a normal blood pressure portended a lower mortality or higher probability of survival. The interesting thing is that for people who couldn't complete the 6-minute walk for whatever reason, as a sign of that they're more frail, for example, that a higher blood pressure in this case actually portended a higher probability of survival. And so I think that in our clinical practice, many of us already notice that we will let people have a higher systolic blood pressure in our frail and older adults, kind of very similar to what our European guidelines talk about, is having a higher blood pressure for those individuals. And so what should we do about this? And it's really interesting that all our guidelines are based upon age. We use age as an inference to functionality and also frailty as well. But over a period of time, as our individuals age, you will see individuals lose their functional status all the way to the point where they eventually have greater disability, become bedbound immediately before they die. And so where exactly would hypertension treatment have its greatest impact? We're not quite certain about that yet, but perhaps this is where it's the best, where people have the highest level of functionality, where we should be targeting lower blood pressures as the person is more functional. But as a person becomes older and they have more and greater disability, that's where we can back off on more aggressive treatment for blood pressure. And that is uncertain, but at least that's recommended at this point. And so I really rather base it upon functionality in terms of treatment of hypertension rather than purely based upon age. And so for those of you in the room, particularly the residents, these are some things that you might even extrapolate to your younger patients. If your younger patients are much more frailer than your older patients, even in terms of age, maybe it's a good thing to start to thinking about functional status and their ability to navigate that versus merely based upon age. Okay. So in conclusion, systolic hypertension is incredibly common in older adults. Age by itself should not preclude treatment. And aggressive treatment of systolic hypertension in frail older adults with many comorbidities is not supported by data and may actually be harmful. I'm going to stop there and just take questions.